Welcome to HEOR Insights. In today's video, we will be discussing the different type of cost in healthcare and the major type of economic evaluations used in the HEOR. When we talk about total cost in healthcare, it is generally divided into direct cost, indirect cost, and intangible cost. Direct costs are further divided into medical cost, non-medical cost. In medical cost, it contains hospital bills, medicines, diagnostic tests, and doctor consultations. In non-medical cost, like travel expenses to the hospital or food and accommodation during treatment. When we talk about indirect cost, it represents the loss of productivity due to illness, such as time off work, when you are not able to go to your work or your office because of the illness, or reduced working ability. Intangible are very harder to measure. They include pain, suffering, or reduced quality of life. Now let's move on to the type of economic evaluations. The first one is Cost Minimization Analysis or CMA. This approach assumes that two different interventions have the same clinical effectiveness. In such cases, the treatment with the lower cost is considered better. However, major limitation is that in real world setting, assuming equal clinical benefit may not always be justified. Second method is cost effectiveness analysis or CEA. Here, the effect of treatment is measured in natural health units such as life years gained, cases prevented, or deaths avoided. We use something called incremental cost effectiveness ratio or ICER, which tells us the extra cost required to achieve one additional unit of health outcome. For example, ICER is equal to cost of intervention A minus cost of intervention B divided by effectiveness of A minus effectiveness of B. This helps decision makers compare interventions in terms of both cost and effectiveness. And when we say decision makers, they are health policy makers, health insurance companies. The next type is cost utility analysis or CUA. This is very similar to cost effectiveness analysis, but instead of measuring outcome in simple units, it combines both quality and quantity of life. The most common measure which is included in this cost utility analysis is QALY and DALY. QALY is quality adjusted life years and DALY is disability adjusted life years. For example, QALY is years of life gained into utility value of health state, and this utility value ranges from 0 to 1, where 0 stands for death and 1 stands for perfect health. The ratio we use is called incremental cost utility ratio. If ICUR is below country willingness to pay threshold, then the intervention is considered cost effective. The last one is cost benefit analysis. In this method, both cost and benefit are measured in monetary terms. This makes it easier for decision makers to compare directly if the financial value of benefit is greater than the cost. And in that case, intervention is considered worthwhile. There are two main ways to value benefit: human capital approach, which assign monetary value based on productivity gained, for example, extra working years saved due to treatment. The next one is willingness to pay approach, which measures how much individuals are willing to pay for a health improvement or risk reduction. To summarize, we looked at the different type of cost: direct, indirect, intangible, and the four main type of economic evaluations, which is cost minimization analysis, cost effectiveness analysis, cost utility, and cost benefit. These are the building blocks of HEOR and pharmacoeconomics. Thank you.